Next, we have our speaker will be Dr. Shelby Sullivan. Dr. Sullivan is an associate professor of medicine at the University of Colorado School of Medicine. She is also the director of the Gastroenterology, Metabolic, and Bariatric Program. She will be tackling the rapidly evolving field of endoscopic treatment of obesity or endoscopic bariatrics. Dr. Sullivan, take it away.
Thank you. I have several disclosures, and I'm sorry, my screen just in front of me went off a little bit, so I'll be looking up at my other screen just for why I'm looking away from you. Several disclosures. I've been involved in a number of research studies for endoscopic bariatric therapies, and I also consult for a number of companies, mostly in helping them get their devices through the FDA regulatory process. So first, just a word on obesity. We all know that obesity is a problem, but the current prevalence right now, we have about 101 million adults who have obesity. And that's defined as a BMI of 30 or above, or 30 kilogram per meter squared. About 24 million of those US adults have severe obesity or would qualify for bariatric surgery, meaning they have class 2 obesity, a BMI of 35 and above, and at least one comorbidity, or a BMI of 40 and above. But it's only estimated that about 207,000 patients underwent primary bariatric surgery in 2018. When we look at weight loss medications, we see that patients who are treated with obesity pharmacotherapy only account for about 1 to 2% of patients as well. And so what that means is that we're effectively treating less than 5% of patients with obesity per year. So this is a drastically undertreated disease. And there are lots of costs associated with that. So at this center, and what we really recommend is that we have comprehensive obesity treatment. And I like to think of this as like the old food guide pyramid, with lifestyle therapy being diet, physical activity, and behavior modification at the bottom. And then on our next rung, we have bariatric endoscopy and pharmacotherapy, weight loss medications. And at the top rung, we have surgery, so reserved for the patients that really haven't been successful with the other things below. Today, I'm going to be focusing on bariatric endoscopy, but what I really want to make sure that everybody understands, even though I'm not going to be talking about it much today, is that there is a lot of combination therapy out there. And in my own personal practice, I do a lot of combination therapy. And what that means is I'm combining devices plus weight loss medications and using lifestyle therapy in every single patient that we see. The other thing to remember is that weight loss probably is the most important thing. You heard in some of those NAFLD lectures about, questions about bariatric surgery. This was a study that was done in my old lab, with the lab that I was previously in at Washington University, and it looked at the effect of weight loss, the same amount of weight loss, about 18% total body weight loss, either with lifestyle therapy or with bariatric surgery. And they did very sensitive and invasive metabolic testing to test insulin sensitivity, glucose homeostasis, beta cell function in a variety of different organs. So beta cell function in the pancreas, but insulin sensitivity of the liver, insulin sensitivity of the muscle cells, and adipocytes as well. And what they found is that there was no difference at all in any metabolic outcome when the weight loss was equivalent. So both of these groups, again, got to about 18% total body weight loss. They were tested before their weight loss or surgery, and then tested at that 18% total body weight loss mark. So what that really says is that you don't have to have bariatric surgery in order to get these beneficial effects on metabolic outcomes. But what you do need to get is weight loss. So there's lots of different options when we are starting to talk about endoscopic bariatric therapies. We don't have them all available in the United States. A lot of them are still under investigation at this point. And I take the primary bariatric therapies. Those are for patients who have not had another surgery. So this is a primary treatment. And I divide them into space-occupying devices like the intragastric balloons, suture plication devices that we see here, the non-intragastric balloon devices that are the non-intragastric balloon gastric devices. And we're going to talk about some of these in our talk today. And then the small bowel therapies. And the small bowel therapies are really thought to have some weight loss independent effects. So while the comment that I made before about weight loss being the most important thing is absolutely true, there are definitely some weight loss independent effects that do occur. So there are still weight loss independent effects of bariatric surgery. And they're really seen more before there's before there's likely significant weight loss. Again, weight loss really trumps everything else. Once you get that weight loss, it really is the most important thing. But at no weight loss, there are some of these independent effects. However, none of those are actually approved in the United States. They're all either undergoing investigation or haven't even gotten to that point yet in the US. So today we're really going to be focusing on the FDA approved devices and those that are have been or are currently marketed in the US. So we're first going to talk about balloons, because this is kind of the oldest of the type, oldest endoscopic bariatric therapy that we kind of have. And we have a number, I'm going to separate these out. We've got endoscopically placed now and swallowable balloons. And then within the endoscopically placed, we've got the fluid-filled balloons. That includes the Orbera, the Reshape balloon, the SPATS-3 balloon, the Silimed balloon, the Medicone balloon. Only some of these are in the United States. For air-filled, there's a heliosphere bag. For air and fluid-filled, there's the End-Embolus End-Ball, Easy Life gastric balloon. For the gas-filled, that's swallowable. That is the Obalon balloon system, and fluid-filled, that's swallowable, is the Ellipse intragastric balloon. Currently, the Obalon balloon system and the Orbera balloon system still have FDA approval in the United States. The Ellipse intragastric balloon and the SPATS-3 balloon, which is an adjustable balloon, they have undergone testing in the United States, but have not yet gotten FDA approval. The Reshape balloon did have FDA approval. It got bought by another company, and they did not keep up on the regulatory process for that balloon. So it is no longer approved by the FDA, but not because of any complications or anything like that. It really was simply a regulatory not keeping up on paperwork reason for it no longer being FDA available. But prior to that happening, it was no longer marketed as well. So the Orbera balloon system is again, fluid-filled balloon. It's a spherical balloon that is made of silicone. It has transoral delivery, and it is placed endoscopically and removed endoscopically 6 months after placement. We put in 400 to 700 milliliters, but typically closer to 500 to 650, depending on the height of the patient. And although it's considered off-label use to dye your fluid with methylene blue, I typically do this because if there is a leak, then that will turn the patient's urine a blue-green color. You can see in this animation the placement and removal. The removal is just the opposite of the placement, which is where we take the balloon and insert a catheter in it, take all the fluid out, and then remove it out through the mouth. It's FDA approved for BMI of 30 to 40 kilogram per meter square, but it can be used in there has been data on using it in patients who have BMI ranges that are above that, and it has been demonstrated to be safe. But you always have to remember, if the BMI is above 40, that is considered off-label use. It's not contraindicated, but it is off-label. The next balloon system that we have is the Obalon balloon system. This is a balloon that's folded within a capsule. You'll see in the image on the right that this is the navigation system for how this balloon is actually placed. It uses electromagnetic localization, and it just popped into the stomach there. So you can see the line of where it was coming through the esophagus and now has popped over into the stomach. The patient will take a deep breath in a second. That will be our second confirmation. There you see that going down and back up, that it is actually in the stomach before inflation. It's filled with 250 milliliters of nitrogen mixed gas, and 3 balloons are placed over the span of 6 to 12 weeks. And again, it's FDA approved for BMI of 30 to 40. We do have data in patients in a BMI above 40, but that is also considered off-label use. Endoscopic removal occurs 6 months after the first balloon is administered. The video here is of the balloons actually sitting in the stomach prior to removal. You can see all 3 of them. They do take up quite a bit of space. It does require an injector needle that has a converter to it so that you can suction all of the gas out of the balloons. And then we grab the balloon and pull it out through the esophagus. In terms of weight loss with these therapies, there's a couple of important things to note. I am including Reshape the data because it did undergo FDA evaluation with a randomized sham-controlled multi-center trial in the United States. And there are some differences with study types. So randomized sham-controlled studies in intragastric devices for weight loss suppress weight loss. So there's more weight loss that we see both in the active arm and the control arm in general in patients who are in open label studies. And this can be seen here in the first group, the this first part of the graph. And in the sham-controlled studies, the blue bar for Reshape and the purple bar for Obalon, we see that there's less weight loss than we see in the green bar, which is for Orbera. However, when we look at the registry, weight loss is about the same. And we only have post-market data for Reshape and Orbera, but again, a little bit more similar. Even when we look out to 12 months, though, even in the FDA trials, we see that at 6 months, all of the patients were unblinded in the Orbera, in the Obalon study and in the Reshape study. And we see that weight loss is really at 12 months, very, very similar between the two balloons. And we only have post-market data completed for the Orbera balloon at 12 months. And we do see, again, about 8% total body weight loss in that balloon. So weight loss maintenance, more than what you would see with weight loss medications. If you stop a weight loss medication, you regain almost all the weight loss you got with it within 6 months, but that's not the same with the intragastric balloons. Serious adverse events are a little bit different though. Now, most of the serious adverse events that we see with the fluid-filled balloons are related to nausea, vomiting, dehydration, requiring IV fluids, and sometimes hospitalization for that. And so we see both in the FDA studies and in the post-market studies that both Reshape and Orbera have significantly more serious adverse events than the Obalon balloon does. So it's really consistently lower, even in the settings where we have registry settings, we still see more serious adverse events in those fluid-filled balloons. But again, those serious adverse events are usually related to accommodative symptoms. We're most of the time not taking the balloons out for this reason. We are able to treat people through it, but it's just something to remember as you're going through the process, because it could affect, you might not be able to go to work for a couple of days. So people also ask, what is the difference between the two balloons in terms of weight loss? And so this is data from both Washington University and the University of Colorado. We pooled our data together. There are very few centers that have both balloons that are actually able to compare them in a consistent program. And what we found is that essentially there is no difference in weight loss between the two balloons at 6 months or at 12 months. We did see that there was slightly fewer patients who had early balloon removal in the gas-filled versus the fluid-filled, and there were a trend towards a difference in patients who needed additional therapy because of symptom control. And in terms of guidelines, the HTA just recently came out with guidelines related to intragastric balloons. And I want to highlight the first point, which is that in individuals with obesity who are seeking weight loss intervention and have failed a trial of conventional weight loss strategies, and I would say that would be commercial weight loss program like Weight Watchers, medically supervised weight loss, the AGA does suggest the use of intragastric balloon with lifestyle therapy modification over lifestyle therapy modification alone. So I think that this is an important point. We really do want to use these therapies in conjunction with lifestyle therapy, but also we want to be using these therapies. It's also important to note, if you think back to that lecture on non-alcoholic fatty liver disease today, that in the intragastric balloons, we are getting above, in many of these patients, above 10% total body weight loss. So we're hitting that mark that we really need in order to see beneficial effects in multiple different disease categories. Switching gears a little bit to a non-intragastric balloon gastric device, this is the Aspire Assist system. And it is like a PEG tube, but instead of putting food in, we're actually taking food out. It's placed during endoscopy with the same technique as a PEG tube is placed. Patients aspirate gastric contents about 20 minutes after a meal. They do that 2 to 3 times a day. It removes about 25 to 30% of the calories that are consumed at that meal. And we actually did a study to evaluate that and had patients eating a meal and had a identical meal that was made, and did bond calorimetry on the gastric aspirate compared to the uneaten identical meal, and we're able to actually determine this. However, it still only accounts for about 50 to 80% of weight loss. So really, lifestyle changes and mealtime behaviors reduce overall food intake, and that is really causing probably closer to 50% of the weight loss that we're seeing in these patients. Food choices also improve anecdotally. What you can see in panel A on the top, and then the lower panel, are the actual tubes themselves. The top panel are the components that are implanted during endoscopy, the A tube itself, and then the skin port is placed after that, but they stay kind of in and on the patient, whereas the components in the bottom panel are only used during aspiration, the connector, the patient line, the companion itself, which just acts as a one-way valve that allows either fluid to go up to kind of move everything around and clear out the drain line, or to open up and allow things to drain out of the stomach, out through the drain tube. But those lines, the patient line and the drain tube, are clear, so patients can see what's coming out. And that, while it may seem like this is kind of an ugh kind of thing, that's actually beneficial because it's also an ick thing for the patients. And it really reinforces good food choices or healthy food choices. Healthy food choices really don't look that much different coming out than they did going in, whereas hamburgers, French fries, greasy food, things like that, they look terrible coming out, and patients don't want to eat them just because of what they visually look like when they were coming out. So that's a really positive thing for this therapy. It's also approved for patients with a higher BMI, so a BMI of 35 to 55 instead of the 30 to 40, which you saw with the intragastric balloons. We have done a meta-analysis on this. So the ASGE recently put out a PIVI meta-analysis on aspiration therapy that included 4 studies at 1 year and 3 studies that went out greater than 1 year. What you can see is that weight loss is really pretty consistent. And even out at 4 years, patients who continue aspirating have about 18.5% total body weight loss. So really consistent weight loss for a long period of time. There were some serious and non-serious adverse events that were noted. Buried bumper occurred in 2.2% of patients. That was partly related to one of the centers that didn't have another method of that was, we believe, were causing the tubes to be shortened a little bit too tight. There was peritonitis after placement in 0.5%, severe abdominal pain after placement in 0.5%, a pre-pyloric ulcer in 0.3%, and a device malfunction requiring replacement. However, the patient did not have any adverse events other than just not being able to aspirate when that device had malfunctioned at 0.3%. So next, we're going to talk about one of the suturing devices, so endoscopic sleeve gastroplasty. You'll see in the top animation how we put lines in the stomach with something called argon plasma coagulation, and then we take that suturing device that's from Apollo Endosurgery, and it's called the overstitch device, and we use that to actually place plications in the stomach and then sew the stomach up. The animation is showing a suture pattern that I do not use, and we currently don't use that often anymore, but it just shows the point of putting these sutures in and really causing an accordion-like effect in sewing up the stomach. We do use general anesthesia for this procedure, as well as IV antibiotics and DVT prophylaxis. In a recent meta-analysis with over 1,772 patients, weight loss was 6.5%. At 1 year and 17.2% at 18 to 24 months. Serious adverse events occurred in about 2.2% of patients, and you saw in that video below what an actual stomach looks like after endoscopic sleeve gastroplasty. However, in these serious adverse events, half of the serious adverse events, again, were related to accommodative symptoms: nausea, vomiting, dehydration that required IV fluids, IV antiemetics. So the vast majority of patients really do quite well with this therapy. What about long-term weight loss with this? Well, we have a single center experience in patients who underwent ESG. There was 216 patients, and this was done at Cornell. From month 3 to month 60 after ESG, there were the vast majority of the patients had more than 10% total body weight loss. And there were a percentage of patients, remember I talked about in the beginning of this at this talk that we do a lot of combination therapies with devices and procedures. And in this series, there were about 27% of patients that had weight loss medications at an average of 5 months after ESG. But what you can see is that weight loss at 5 years was 15.9% total body weight. And they had about 80% of patients that followed up at that 5-year time point. So really good follow-up. That is higher than most bariatric surgery follow-up series, and really demonstrates the fact that this therapy, while some of the sutures may start to wiggle out over time, for the most part, it really is causing some consistent changes in the stomach itself. So I usually tell patients that although maybe early on, within the first month or so after the procedure, that it might be considered reversible, it's typically not really reversible. I'm just going to touch a little bit more on secondary treatment. So this is for weight regain after gastric bypass, likely multifactorial, and occurs in about 25 to 30% of patients. However, the diameter of the gastrojejunectomy correlates with weight regain, and you can see that demonstrated in this study here. 59% of patients had regained greater than 20% of the weight they lost. 41% had weight loss maintenance, all underwent EGD for clinical reasons, and the gastrojejunectomy was measured. And what you could clearly see is that there's this pretty strong correlation between the diameter of the gastrojejunectomy and weight regain. So we've come up with transoral outlet reduction, which is currently in the United States uses also the overstitch device. And we're essentially using argon plasma coagulation around the anastomosis and then sewing it up. There are different types of suture patterns that you can see here: interrupted, purse string, and weight loss predictors are really the diameter reduction that we see, the type of technique per string, and then the interval of the gastric bypass to the revision itself. And just to show you a couple of pictures here of what it actually looks like, this is a dilated gastrojejunectomy here. This is pre-APC and per string APC. It's argon plasma coagulation. Again, it's cautery. It's inducing that burning, which will help with scarring. This is after the APC and sewing down with using the purse string technique and kind of pulling that tight right to 8 millimeters. I also typically put sutures in the pouch as well to shrink that. This is the same patient. She had a very large pouch. Gastric pouch really shouldn't be larger than 3 centimeters. This one was 9 centimeters. And you see that we're suturing that down as well after suturing the anastomosis. In a randomized sham-controlled study, using a device that was not a full thickness device, the current device we use is a full thickness suturing device, there was still significant weight loss or weight loss maintenance in 96% of the patients compared to the sham control. And you can see in the graph that there's significant difference in weight loss between the two groups. We also have some long-term data on this. This is from a single center in Boston, and we see that we have weight loss out at 1 year, but even at 5 years, we have almost 9% total body weight loss. And again, this was in patients who had gastric bypass and were consistently gaining weight before they had the procedure. They had no severe adverse events, but they did have some moderate adverse events: abdominal pain, some melena in a couple of patients, stenosis and erosion. They also had some additional therapies, again, going back to this concept of combination therapy to treat patients with obesity. So in conclusion, endoscopic bariatric therapies have significantly more weight loss than lifestyle therapy alone in randomized controlled trials and really should be considered for obesity treatment. Primary endoscopic bariatric therapies have less complications than bariatric surgery. There's multiple different kinds. They vary in complexity, weight loss, and complications. And endoscopic revision of gastric bypass is both safe and effective. Thank you.
Thank you so much, Dr. Sullivan, for this passionate discussion about endoscopic bariatrics. Great talk as usual.